My name is Peter Biesenbach, and I'm an emergency physician from Denmark, from the University of Southern Denmark, where I'm also a researcher. And I would like to thank the organizers of the Acute EOL for inviting me to present today. It's an honor, it's a great opportunity, and I really enjoy and love the idea of Nordic collaboration. As you all know, there's an increasing number of patients coming to the emergency departments everywhere. There is the so-called silver tsunami, boomer generation going on pension and retiring, becoming nursing home residents. More and more elderly patients coming to our departments and flooding them. One aspect of management which we particularly focus on at our department is to transfer management of these patients more and more to the outpatient or pre-hospital sector. And I want to present two methods we have employed here at our department. When you go home tonight after a long congress and you talk to your department heads and hospital administrations, you might say, oh, I don't remember much from the congress because I drank too much. I remember two things that the Danish said, and that's I should buy a car and I should buy a phone. And this will make sense at the end of the session, I promise, all right? So what kind of car am I talking about? What kind of service? This is what we call a very new and innovative way of pre-hospital care, which we do or offer at the hospital in Esbjerg, where I work. It's a medium-sized hospital, about 350 beds or something like that, 38 ED pods, and we have a case mix with approximately 40% of injury or accidents, and the rest is a mix of medical, abdominal surgery, neurology, cardiology, etc. We have about 8,000 admissions a year. And what we did in 2023 was establishing a car. Let's have a look. Should be a video. I hope the sound works, and I hope your Danish is good.
Tilbud til patienter, hvor de ikke nødvendigvis har godt af at komme på sygehuset, men omvendt har behov for en mere specialiseret behandling end det læger i vagtlæge eller almen praksis kan tilbyde. Det er et værktøj, vi tilbyder til alle sundhedsprofessionelle i primærsektoren. Det værktøj består af en bil med en akutmediciner og en sygeplejerske, samt udstyr til at lave højt specialiseret vurdering hjemme hos patienten. Den mobile akutmodtagelse har kørt siden september 2023. Vi kører lige nu til patienter, der er på plejehjem, på midlertidige pladser, og så er vi begyndt at køre til patienter, der er udskrevet fra sygehus inden for de seneste 72 timer. Derudover så er vi begyndt at køre til nogle patienter på psykiatrisk afdeling og forventer at udvide det her i løbet af foråret. Hvis det produkt skal blive endnu bedre, så har vi brug for input fra dem, der kender patienterne rigtig godt derude. Vi kender patienter, der er på sygehuset, men almen praksis, akutteams, plejepersonale på plejehjem, de kender deres borgere langt bedre, end vi gør, og er langt bedre til at spotte, hvor det er, vi kan komme ind og give endnu bedre tilbud, så patienterne slipper for at komme på sygehuset. Jeg vil rigtig gerne invitere til alle, der arbejder med borgere ude i samfundet. Praktiserende læger, plejehjemspersonale, akutteams, socialarbejdere. Vi vil rigtig gerne i dialog om, hvordan vi kan gøre det her tilbud endnu bedre til deres borgere, så de slipper for at komme ind på sygehuset.
So this is the mobile emergency unit. It's a car, pretty simply said. An electric vehicle in a Mercedes with a range about 500 kilometers, 400 to 500, depending on the weather. It's staffed by an emergency physician, a specialist in emergency medicine, and an emergency medicine nurse. It operates daily between 8 and 18, so 10 hours every day of the week, every day of the year, 365 days a year. And what is unique about it is that we take responsibility for the patient. So our goal is technically to assess and treat the patient at home whenever it's possible, and then we keep responsibility for up to 4 days after the treatment has finished. That means for a general practitioner, this is very, very interesting. Instead of just sending an ambulance and having a quick assessment, they have someone who is taking over the care of the patient in this setting when there is acute, sometimes even critical illness. This was from the day when we opened. One of the very important politicians, Stephanie Lose, was us. They always come with those huge scissors, golden scissors, and then clip some bands. So it's very good opportunity to actually make some allies among politicians because they like and love systems like that. Let's do a quick case because it's usually very abstract for some of them, for some of the listeners. We have a patient. She's called Mette. She is suffering from a cognitive impairment. She's living at an assisted living institution where she gets help with her daily challenges. And Mette has had some kind of cellulitis in her left lower leg or extremity. She has been started on oral antibiotics for the last 3 days. She has been prescribed antibiotics, and she's still febrile, and her overall state is slightly in decline. So the general practitioner calls an ambulance and wants this patient to be admitted to the hospital. This is where we say, stop. We have perhaps an alternative management pathway for this patient. So we drive out, the nurse and the physician. We assess the patient on site. We do blood tests if necessary, blood cultures if necessary. We do venous blood gas, CRP tests if necessary. We do a clinical assessment, and then we take all the information and make a treatment plan for the patient at their residence. For example, for Mette, it could be starting IV antibiotics, perhaps double treatment with penicillin, dicloxacillin at her residence, activating the municipal nurses to take over care afterwards. So we only do one visit and then finish from our side, but we still have responsibility. We might start fluids if necessary. We might give other medication, do an ECG. But we have the medical legal responsibility, but the patient doesn't have to come in. She doesn't get confused. She doesn't get stressed by hospital admission. And it saves a lot of money in the end for the health economic system or the hospital system. How does it work from a workflow perspective? It starts with an activation, which means there's either the EMS, the dispatch, that calls us with a patient and says, could be an opportunity for you guys. Or it could be the GP or the nursing home that calls us and says, we have a patient in decline. Couldn't you come and make an assessment and start treatment here at the residence because there has been a treatment care plan that said no further hospital admissions for this patient. It's always the emergency medicine physician who makes the call, is this the right patient? Is this appropriate or not? Then, as I said, we drive out, the nurse, the physician, make on-site assessment and start treatment, initiate antibiotics or whatever. And then there is an ongoing evaluation. They might call in the day after or 3 days later when we agreed upon a follow-up phone call where the nurse, the municipal nurse or the nursing home employees have taken a CRP level 2 days later or 3 days later and say, the patient is well, everything is going fine. And then we can say, okay, we just switch back to all antibiotics and we finish the case. Thank you so much. Obviously, there are also patients who do not improve. Then we have ongoing discussions. What is the next step of escalation? Is it ED admission? Or should we revisit the patient? Do we do also follow-up visits in these patients? We have a lot of equipment with us. You can see as a nurse in the mobile emergency unit, you have to have a lot of muscles to transport all the medication and equipment. There is handheld ultrasound, the butterfly. We have currently about 55, 57-ish drugs from adrenaline, amiodarone, anything, you name it, tranexamic acid in the chest. We have drains for thoracentesis, paracentesis, for example, for palliative patients who have malignant ascites. We do, as I said, blood gas, CRP, blood cultures. We have a defibrillator, obviously, oxygen, suction. Almost a complete emergency department. So, does it work? What does the numbers say. We did a retrospective cohort study over 16 months, and we had, as a primary outcome, defined admission avoidance. We looked at 2,145-ish contacts, and after some data, missing data exclusion, we had about 1,300 patients, individual patients. So there were several patients who had several contacts. There are a couple of patients who are frequent flyers, you could say. Among these patients, what you can see is that they are, approximately half of them are nursing home residents, and a lot of them are frail and multimorbid. About a third of them have more than 3 comorbidities, and 25% or so, every fourth, is known to have dementia. So that's actually a rather sickly population compared to a standard ED population. And we also have a rather significant focus on the elderly. So if you look here, the median age of our patients is about 80, and more than 85% of our patients were older than 70 in this analysis. What are the complaints? It's pretty much everything. So we don't exclude specific complaints in or specific reasons when we see these patients. So it may very well be respiratory conditions, respiratory symptoms. Very common is also a general decline where they can't really put words on what's happening with the patient, what's the issue. There's a lot of patients with pain, unspecific pain. There is a lot of diarrhea or gastro issues, and obviously patients who had a fall and with a low energy trauma, which have to be assessed for a fracture or hip fracture, dislocation, etc. If you put it into management groups, to make it a little bit more simple, I would say about half of them are infections, urinary tract infections, cellulitis, pneumonia, and about 12% have palliative needs, end-of-life care, and then there's also a rather large proportion who requires fluids. This is the overall, if you allocate it in larger groups of diagnosis. So when we look at our outcomes, we did about, in 60% of patients, we did blood tests, ultrasound in about 25%, antibiotics in 30% of patients, and we kept 83% of patients at their residence. And this is extremely positive if you consider that all of these patients would have ended up in the emergency department if that service had not existed. So 83% of patients can be managed solely at home through this service in our analysis. We also just published an analysis on the risk factors of admission, where we looked at odds ratios for comorbidities, etc. And surprisingly enough, there's only 2 things that make it more unlikely to keep the patients at home. The one thing is that people who are not at nursing homes usually don't have the level of care already established. So it's more difficult to keep people who live at home in their home compared to nursing home patients. At the nursing home, they already have workers who can check up on them, do, for example, vital signs, compared to people who live at home. And people who have an established do not resuscitate order are also more difficult to keep at home, and that's perhaps a little bit surprising. But this is especially people who are living at home and have a do not resuscitate order, have very complex medical needs at their end-of-life stage they currently are in. And this is increasingly difficult to manage at home. So, I mean, it still works, but this is a risk factor, or this is less likely to be possible to manage fully at home. Then we also did a satisfaction survey, it's unfortunately in Danish, where they answered 100 patients and relatives that more than 90% felt safe being managed at home. Their expectations were met in about 90%. They would clearly recommend the service in about 90% of cases, and especially high was the personal contact. So they felt really met. They felt like someone was doing personal medicine for them at their residence. Is it safe? Well, what's safe? We looked at survival, and if you consider 90 days mortality of about 25%, it's rather significant. So this is a population which is frail, has many comorbidities, lives many of them at the nursing home. So the mortality is expected to be high. We consider this safe because we know that these patients usually, the majority of them, they already have expressed wishes that they do not wish further hospital admissions and that they prefer treatment at home, and they accept if there would be a high risk associated with that. So let's take another case. This is Astrid. She is 86 years old. She's a nursing home resident. She has a little bit of dementia, but good quality of life to a certain degree because she's still enjoying her day. She is frail with a clinical frailty scale of 7, so she needs help with pretty much everything. And she's being found unresponsive this morning in her bed. She went to bed fine last night, tucked in, everything well. This morning, GCS4, agonal breathing, very superficial, some gasping, and one pupil is large. Who would like to have this patient admitted in their emergency department? Please raise your hands. Who gets patients like this admitted to the hospital? Well, in the olden days, there would be a rather significant chance that either an ambulance would just pick up the patient and drive with blue sirens to the hospital, and we would activate a medical emergency call, and everybody would say, yeah, okay, we have to do it. Or even worse, an anesthesiologist would find the patient first and tube the patient, and then it would be more difficult to go in the way of comfort care. Because obviously, this is the focus here. We have to identify reversible and irreversible causes of acute illness. And Astrid here has a catastrophic bleed, probably intracerebral bleed, and no neurosurgeon in Denmark will touch her. So what we would do in this situation, we would drive out, we would assess the patient, we would talk with the relatives, talk with the personnel at the department or the nursing home, and then I might call a neurosurgeon and say, would you like to have Astrid in your neuro ICU right now? And then he says, thank you so much. There is no treatment offer from our perspective. She's not a candidate for advanced neurosurgery. And we agree, we say the most appropriate care pathway for Astrid is acute end-of-life care. That means to stop treatment for life prolongment and shift to symptom relief comfort care. And this is something that's actually rather huge in these patients or in this cohort of the mobile emergency unit, because a lot of these people actually have acute end-of-life care needs. And it's difficult to define what is acute end-of-life care. We define it as to provide symptom relief at home when death is expected within hours or days. So this is not palliative care where someone has weeks or months to live. This is dying now within hours or maximum days. We analyzed a subset of patients that received acute end-of-life care. It's about 130 patients. All of them wished to stay at home, or the relatives wished them to stay at home. So we don't force anyone to stay at home or to die at the nursing home if they don't want to. But all of them wanted to, 5.6% of overall contacts, and about 77% of those had actually a do not resuscitate order, but only 50% had established levels of care, such as I don't want to go to the hospital anymore, or I don't want the respirator, or I don't want that or that. So that's still something we are struggling with in Denmark, to make advanced care plans actually for these patients, especially at nursing homes. And what we found was that 98 of patients died a dignified death at home. That's 127 out of 129. Only 2 patients out of this cohort had to be admitted because the staff felt unsafe or had safety considerations. 98%. And we used approximately 1.8 visits on average per patient, which is not much. We usually take like an hour and a half in the beginning to talk to the relatives, talk to the personnel. So there is a little bit of time investment, obviously. And patients had a median time until death of 3 days. So very successful from my point of view. The second part, talking about the phone and why you should buy a phone, is tele-emergency medicine. This is even more difficult to define. I wrote this after suggestion from ChatGPT. The use of telecommunication to provide emergency medical care remotely during acute situations. All right. So we did a study last month where we wrote to all the emergency departments in Denmark. The red dots, there's 21 emergency departments. Do you have tele-emergency medicine, and how does it look? How many hours, how many patients, etc. How many of you have tele-emergency medicine? Yeah, like perhaps a third or fourth. We asked them, and 50% said yes, 50% said no, but there's still a lot of confusion what the definition actually is. And if you look at the numbers, 50% doesn't make sense with 21. So there's something missing, because one head of the department said he doesn't know. He just didn't know if they had tele-emergency medicine at that department. But she was just started recently, so that's okay, I guess. So how does the workflow work again? In Esbjerg, if there is tele-emergency medicine, it's usually that the patient starts with a 911 call. So for whatever reason, the patient calls an ambulance and says, I'm unwell, I need an ambulance. The ambulance drives to the patient, arrives, and makes an assessment like they usually do, a paramedic, ambulance personnel. And then, when they have taken vital signs, when they have performed their assessment, their examination, they screen the patient, and they say, I think this patient could stay at home. So it's primarily the ambulance people, the paramedics, who make the first screening. And then they call the emergency physician 24/7, no matter what. They can always call and say, I have this patient, and I would like to leave the patient at home. Treat and release. The patient stays at home after stabilization. Which patients do we take? Adult patients. Any patient that wasn't a siren call. So if the patient if there is consideration for a cardiac arrest and they drive out with blue sirens, then they are not allowed to just treat and release. But everything else goes. If you're comfortable with releasing chest pain out in the field from a medical legal perspective, then you can. There's nothing against it. So let's take another patient. Josephine, she's 72 years old. She's actually living at home, a little bit of help perhaps, once a day from a home nurse, a municipal nurse. She has COPD and had a couple of days where she could feel that her breathing was getting worse. The ambulance arrives after Josephine had called 911. They start management. They start treatment. They're giving her some better mimetics. Perhaps they're giving her some oxygen to start. And eventually she's feeling better. She's feeling comfortable. She says, actually, I would prefer to stay here. I feel safe. The oxygen saturation has increased to 89% perhaps. And she wants to stay home. So they call us and we make a treatment plan. We could agree upon a dose of corticosteroids through the ambulance perhaps, and then I make a prescription which she can pick up from the pharmacy. So she has the option to stay at home with a plan, and she has also the option to escalate at a later stage, but it's not planned. We release the patient. They can always call again the ambulance, but we don't keep responsibility for these patients. We did a retrospective analysis, again, a cohort study with 633 patients. These are much younger. There's a lot of psychiatric patients, patients with other needs than we previously discussed. About half of them is female. And interestingly enough, 8% had been consulted previously with another specialty. But they don't feel comfortable with releasing patients. A cardiologist has extreme difficulties with saying this patient's chest pain are not cardiac and he can stay at home. He feels very comfortable with saying this patient's chest pain is not cardiac and he can go to the emergency department. But he will never say, just keep him at home, I take responsibility. So they first consult with a cardiologist sometimes, and then afterwards they ask us, could we not just keep this person at home? And I can already start with the outcome. 98.6% stay at home, actually. So we release almost 99 out of 100 patients on site. So the screening process by the ambulance people is excellent. Perhaps it's not aggressive enough, actually. And if you look at admission rate, here on the left-hand side, it's 48-hour admission rate. There's about 8% of these people in total who are being admitted within 48 hours. So we admit 1.5% already at the start, and then it increases after 48 hours. So there are some people who actually have the requirement of hospital care, or who cannot manage completely alone at home, and that's fine. I mean, if you had an equal number of admission rates also after 48 hours, this would even more show that we are not aggressive enough with identifying patients that can be managed at home. After 30 days, admission rate goes up to 20%, but that's fine, because this is about urgent emergency admission now. There's a lot of patients where they try to do something else with the GP, where they do further testing, further treatment. And if that doesn't work, eventually they might have to do a hospital admission. And that's okay. So how do we follow up with these patients? As I said, we don't follow up, but we suggest follow-up through other means, or we organize follow-up. In 25% of cases, here on the left, we contact the general practitioner, or we advise the patient to contact the general practitioner for follow-up. In certain cases, very few, we organize a nurse to come and make a tryghedsbesøg, an extra safety visit, or we refer to an outpatient clinic where the patient already has some kind of management in place. Could be like if they have a lot of diarrhea as an inflammatory bowel disease patient, we could organize a visit the next day because we have slots for that actually. But 70% did not require follow-up, and the mortality at 30 days is only 4.2%. And this is actually lower or in the range of a general ED population. So this is a very, very safe intervention overall. How many patients do we manage out of the hospital annually at our hospital? There is the 1,650 approximately with the car, the mobile emergency unit, about 1,200 through the ambulance people with tele-emergency medicine, and something I'm not going to talk about too much now, that's called Radiomedical Denmark, which is maritime health for seafarers on Danish flagged ships, where we manage about 4,000 people, seafarers annually, remotely, without hospital admission. So you could say we have 7,000 patients that we manage remotely compared to the, 42,000 people that come to the ED. And if you only look at the patients who have medical conditions, I mean, excluding the injuries, then that's almost a third of the total patients load, which we manage in addition as outpatients. What's next for our department? What would we like to improve or innovate? One thing is especially more research in regards to cost effectiveness. How much money are we saving the hospital? Because currently it is the department that's paying for the car, and it's not that cheap, so we would like some compensation for that. We would like to expand the opening hours of the car until around midnight, because we know that there's several cases spanning into the late afternoon and night. So this would help tremendously with that. We would also like to have more advanced telemedicine opportunities. For example, if the ambulance has a patient they release with a borderline oxygen saturation, it would be very helpful to have a package you could deliver to the patient with a tablet and a pulse oximetry, so they can measure oxygen at home during influenza season, and they can report back and say, no, now it's 85%. All right, now you have to get admitted because we can't manage anymore. So this would be a very, very good opportunity to expand. And as I said, the ambulance people are very good to screen people who can stay at home, but there's also personnel at nursing homes and other institutions who might very much be interested in this kind of service. Yes. As I said, when we finish this talk today, you will remember 2 core messages. You will take them home to your hospital administration, to your leadership, and you will say, well, we should buy a car and we should buy a phone. And as I said, the phone especially costs you nothing. It costs you absolutely nothing because you have 24-hour coverage with an ED specialist already at your department, I guess. The only thing he has to do is take up the phone 5 times a day, if you have the caseload we have approximately, and say, well, that sounds reasonable. I think I feel safe with keeping the patient at home, and if she gets worse, she just has to call again. This takes you 10 minutes, 15 minutes perhaps per patient, maximum, with documentation, with everything set up. And as I said, from a hospital perspective, this is very cost effective. If you need help implementing or have further questions, you can ask Henrik. He's just sitting there in the third seat. And he's the head of DASEM, as you probably know, and he also is our pre-hospital expert and has been implementing these innovations, or he was part of the team at least. And he has a lot of experience, especially with the barriers of implementation, who to talk to and who is a potential ally, etc. Otherwise, if you have more questions in regard to research or research collaboration, I'm very happy to to be contacted. This is our research unit last year at USEM in Vienna, and thank you so much for your attention. Yes? The box.
Yeah, thank you for a very nice presentation. I'm Anna from Finland, and we have had this for 10 years. I think we have 3,000 patients nowadays per year, over 20,000 visits, and I don't even know the number of telemedicine patients taken care of. It's like over 10,000. But and our population is only 210,000. So, and we have the cost effectiveness data. We are just not very, we don't have the hands to publish these things. But the one question, have you thought about, because we have the next step, and the next step in our system, I'm not sure if you already have that, is that we are diverting certain calls straight from 112 to our services. Do you have this already in use?
We don't have such an advanced service as you describe it. That means we are still dependent on the dispatch. So the dispatch has responsibility to send an ambulance, and they can identify patients for us. So that's one part of the group where we don't screen ourselves. It's the dispatch that screens for us. The other part is where the GP or municipal nurses, etc., they have a lot of patients where they feel they could really benefit from the service. So they directly contact us. So by that, I think we already bypass standard dispatch services, but only to a certain degree, like 50%. Yes?
Hello, Mantas Hokas is my name, and I am chief physician for Stockholm ambulance service, physician man service, where we also do that type of work, which we do just in a bit of a different setting. And to answer your questions, and it was really interesting that you brought up the antagonism which you might have experienced from the ambulance service. In our case, we have 60 individual doctors employed in ambulance service. Part of them are emergency physicians, and we do have cars doing this 24/7, but not at that type of work and not along those lines. But our doctors also rotate into the dispatch. So the ones who are working in the cars, they sit also at the dispatch. So I think that was my comment to your question. If you would be able to get this working in your system, I think that could be a partial way to go. But otherwise, thank you very much for this data.
Thank you.
Yes, Peter. Now for my question. The phone service, I'll buy in on that. The car, it's a Mercedes solution. It's a very nice solution for those patients that you treat. But you treat on average between 3 and 4.5 patients a day with one nurse and one emergency medicine specialist. In my department, I could use that resource more efficient in the hospital. So, okay, it's good for the patient, but I need that resource because I need it for the rest of your 115 patients you have in your department a day.
Excellent question. It's about cost effectiveness because the numbers are 1,600-ish patients a year. So that relates or comes to 5 or 6 patients a day. And there's also a couple of downtime days where there was sick leave, but it's about 6 patients a day they usually manage to see. But you have to consider, what's the difference between a paramedic in an ambulance and this service? If there is no call for a paramedic, he just sits and drinks coffee, I guess, because, he can't pick up patients that don't exist. If our service is not activated because there is a lack of patients, then they just go to the ED and work. They just see regular patients. So this is an extra aspect you don't see here. The physician and the nurse are working, no matter what, either pre-hospital or intra-hospital, and that's a huge benefit compared to legacy EMS services, I guess.
Yeah, it's not only ED, so you have to, when you make the cost analysis, you have to consider that as we have the 3,000 visits per year, the 3,000 patients per year, it means over 20,000 visits. So it's also taking a lot of burden off from the wards. And actually, we are one of the EDs in Finland that has least problem with crowding, since the patients are home and nurse sees them sometimes. It's much cheaper than keep up a ward. We have been closing a ward because of this.
We can actually see last year we had a period of downtime because of sick leave, where they closed the car for a couple of weeks, and you could see in the hospital numbers, the numbers of admissions, percentage-wise, even increasing from 28% to 30%, and also the number of the block, how many patients have to stay longer in the ED because there's less availability up on the wards. Absolutely true.
Yeah, but there's a caveat. Since we have had this for 10 years and we are treating a lot there, all the easy cases are gone. So our population in our ED, it's a very, very tough population. So you have to be very careful that you are not letting go of your resources at the same time, because our waiting times in ED are getting up, though our patient numbers are going down. And that's because of all the easy patients are gone. they are they are at home.
Well, thank you so much. The time is running out, so if there's any more questions, I'm happy to answer in the lunch area. Thank you so much.